So, hello to everyone. We are here, Elizabeth Rivas and me, Lalis from Cuberta. We expected also Oriol, but he couldn't meet us, so maybe he will join later. But actually, we want to share you how we are combining the lean methodology with customer experience methodology. We will be focused on talking about the healthcare sector. So you'll see patient, but it's the same as when we talk about customer experience. So Elizabeth will first of all do an introduction, more a theoretical part, talking about how we combine both methodologies. And later I'll be explaining to you how we apply these methodologies, but with a real case that we are working today. So hope you enjoy the session, and please, if you want or you have any questions, you can write it down, and then we can chat later at the end of the seminar. Hope you enjoy it.
Great, Alice. Thank you so much. So good morning and good evening to everyone. Welcome to this webinar called Design Care Through Lean Eyes and Patient Voices. My name is Ellie, and as Lalis said, today with her, we will explain to you how we have combined these two methodologies on this hospital at home example that we will show to you. As Lalis said, in this project, we have applied these both methodologies in order to redesign the current healthcare processes at hospital at home. But above all, we have done it while keeping the patient's voice at the center. So before getting into this specific case, first of all, we would like to share with you how we have combined these two methodologies. So first of all, let me start with a question. When we map a care process, where do we usually put our attention? Typically, we focus on visits, on tests, on the time it takes to perform them, because after all, what we want is to optimize the process, optimize the flow. But what happens between one visit and the next one? In that space, it can happen many things. For example, anxiety, doubts, waiting, fear, things that the professionals don't see, but the patient feels. All of that usually doesn't appear in our diagrams, but it shapes the perception of care. Actually, the patient's experience begins long before the first contact with the healthcare system and often continues after the last visit. So if we just look at the process from the professional's view, we are missing half of the story, and that is why patient experience comes in. Here we have a patient with lupus who told us, I am being treated by 9 different specialists. I feel like I'm being bounced from one place to another. With this simple quote, we can see that the problem is bad coordination and internal organization. Also, the patient told us, waiting is annoying, but if you let me know, I will go and get a coffee. Or a doctor who tells us what medication you need to take but doesn't write it down. How many times have we asked for directions and then you don't remember them? So with medication, which is extremely important, shouldn't they write it down by default? This shows us that it's not really about waiting itself, but how about we communicate and how we manage expectations. If we provide the right information and help the patient understand what is happening, the experience improves. And as a result, our workflow will become smoother too, because we will have fewer interruptions, fewer questions, and therefore less frustrations. In fact, from the Beryl Institute, one of the global leaders in patient experience, they did a study and found out that the factors that most influence in patient experience are the process themselves and the way professionals communicate. And those are exactly the same elements that we aim to improve when we implement Lean projects. So we can clearly see how processes and patient experience are deeply connected. Okay. So why do patient experience? In many Lean projects, we tend to include only healthcare professionals, which means we end up capturing only their voice and their opinion. However, patients usually have a different perspective, and we need to include that too. Therefore, there is often a gap between what professionals see and what patients perceive, feel, or experience. And our challenge, after all, is to try to reduce that gap. So now, how do we combine these two methodologies? For that, we need to go back to the first lean principle, which says value is defined by the customer. So if we are working in healthcare, who is our customer? Exactly, the patient. So right here in this first principle is where patient experience fits. Therefore, if we want to define real value and generate real value, we need to listen to the patient to truly understand their needs and organize the processes around them. Then we must apply the principle of continuous improvement, which means that we must include the patient's voice on an ongoing basis. Otherwise, we will be only improving through the professional's point of view. In healthcare, quality is built on three major elements that complement each other, which are treatment effectivity, patient safety, and patient experience. So by incorporating patient experience into our projects, we are intrinsically improving quality, which, as you know, is one of the main indicators that we strive to enhance in lean projects, as well as safety, delivery, cost, and people. So maybe right now you are wondering, well, okay, everything is, I understand it, but how do you put this into practice? So we will explain it really briefly. To be honest, there is no single formula, but we use the design thinking, where the phases empathize and define correspond to the left side of the A3 report, and create, prototype, and test correspond to the right side of the A3. We always start by identifying a problem or an opportunity. It could come from a complaint, a suggestion, a strategic initiative. From here, we create a working team, and we must train them in lean and patient experience methodologies. Then we have to define the project scope. After this, we need to identify which type of patient we need to listen to. Since we can represent the whole patients, we need to define archetypes, groups of patients which have similar attitudes, motivations, and needs. And how can we capture their voice and opinion? So we can use here different techniques, such as the direct observation, the shadowing, which consists on following the patient throughout their care journey, focus groups to generate discussion and shared insight, or individual interviews if we want to explore their experience in a more deeply way. With all this information, we create the patient journey map, which is a visual tool that shows the patient's full experience through the whole process and highlights both pain points, which are opportunities for improvement, and the aha moments, those pain points where the patients feel truly well cared, and therefore there is no need to change them. From here, then we co-create solutions, we prioritize them, we implement them, then we analyze the results, and last but not least, we need to evaluate and gather all the continuous feedback involving again the patients once again. That is what truly closes the PDCA loop. So from here, Lalis will explain to you how we have applied and combined these two methodologies in a real hospital at home case. Thank you.
So thank you very much, Ellie. And now exactly, we are going to explain you how we apply all what Ellie has told you, but in a real case that actually we are still working on this project. Just let you know that we are going to talk about hospital at home. This is not a project that only participates one healthcare organization, so it's a sum of different healthcare organizations. Here you can see the several ones that are participating. It's funded with European funds, and actually it's like we are carrying out in Catalonia, in Spain. I'd like to introduce you a little bit what is a hospital at home. So we asked Dr. Piera Sergio that share us some pictures that really makes you understand what is hospital at home. Because actually our people, if you are not very known with the healthcare sector, just let you know that hospital at home is people who is hospitalized, but they are not in a hospital, but they keep at home. So it's important to understand where they live, because actually all the people, the professional healthcare professionals and the resources needs to move from the hospital to their homes. So here you can see, for example, how the saline bag is holding on the fish, on things like that. And here you also can see how accessible are these homes. So some of them are in the city, but some of them are not. So you need to take this into account, because it's not as doing lean in a hospital basis. So you need to understand what is going on. So if we move forward, actually here the purpose of the project is to build a more accessible hospital at home, also improving quality and safety. Always we seek this with lean projects. Strengthen also coordination among professionals. These patients normally come from the hospital or from other healthcare organizations. So we need to make sure that this coordination works properly, because otherwise these patients will be hospitalized in a hospital. So we don't want them to end in a hospital, but to stay at home, and actually adapt the model to real needs of patients and families. So include all these perspectives. And how we are gonna do, or how we are doing this. So we are doing reengineering of the process. Also, we will have a digital platform we will talk about later, and we want to include the patients and families' voice. So we have split the project into 3 different subgroups: acute care, intermediate care, and mental health, because the clinical aspects of these patients are so different among them. So even all of them are hospital at home, the patients who are behind, the people who are behind these treatments are very different. If you are not familiar in healthcare, acute care is like all are these patients who are clinically stable but still require medical follow-up. Intermediate care are normally more elderly people who they have chronic disease. And then there are mental health that probably people is younger sometimes, and they need some approach, but in a specific time of the pathology. So once we have distributed into 3 different groups, here you can have how we are combining the methodology that Ellie has explained you before, how we put this methodology through the A3 lean thinking. So as you can see here, and if you are familiar with lean methodology, with lean projects, here we have an A3, but this A3 is completed through the customer experience methodology. So if you click, you can see like we are gonna follow this structure to explain you what we have done in this project. So the first point is to the title, rethink how hospital at home should work, improving coordination, efficiency, and user experience. Good. We already understand what we are expecting with this project. The number 2, the context, we try to redesign the hospital at home model through process reengineering and the incorporation of patients and families' perspectives, as I have already said. But this is important because we were not trying to fix a gap, but about evolving the model to make it more coordinated, accessible, and patient-centered. And this is important because when we start asking patients and families how they feel about the service that they were receiving, the experiences is very good. They really like to be at home. So it was very tricky for us because the experience was already very good. The coordination was already very good. So we need to move forward and to see how we want to evolve this service that they already consider that is high, that professionals are are delivering a good service. So once we have the title and the context, then it's about the actual situation. So here you can see all different tools that we have applied. And now we will show you how we have used all these different tools. So if we move forward, the first thing that we have done is understanding the process. So you'll see now all the information that we are sharing are a mix of the three subgroups, because we want to show you a little bit of the different three subgroups. This one was about the acute subgroup, but depending on the subgroup, all of them has follow for the same process. So first of all, we create a group with healthcare professionals to understand the process. So how was the referral decision? How was the referral process? How was the hospitalization, meaning at home, and the discharge? This was the first part of the process. Once we have understood the process, we try to identify different archetypes, because even we have three subgroups, within each of the subgroup, we have different type of patients. And this was very important because not all of them need the same. So for example, here you can see the mental health subgroup. You can see that we found three different archetypes: Kevin, Laia, and Alex. Kevin is like a young and unstable, struggling with addiction and routine. Laia, an adolescent searching for a meaning. And then we have Alex, who is more stable but vulnerable to clinical relapses. So as you can see, the three different profiles has anything in common. So taking this perspective into a lean project has allowed us to design a better process and three different processes for each one of them. So once we have the different archetypes, we move on and we continue exploring different needs. So we've been reviewing different satisfaction survey that the healthcare organizations already had. We've been also doing a lot of interviews and focus group with patients and also caregivers. And then we realized when we did the archetypes, we realized that we missed one, which was very important at hospital at home, which were the relatives and the caregivers. So we need to include also this archetype as one group very important in this type of in this project and in this kind of service. And then we also go to different homes and did Gemba observations. With all this information, actually, we could ended up with a patient journey map, with a customer journey map. Here you can see one of the archetypes. So here we have what they are doing in all the different parts of the process. So since the discharge, the hospitalization, and also when they are deciding to access to the hospital at home. Then here we have different dimensions and also how they are experiencing. How is the experience and what things we need to take into account to improve this experience. So with the value stream map and the patient journey map, we are still doing a lean project. So we also need to understand and to collect a lot of data. So we take some clinical needs table, this autonomy needs table, also data collection, and actually what we wanted to understand is how many patients were treated at hospitals that can be treated at home. So this is also a gap that we are against too. So we are trying to collect, let's say, or identify what are those kind of patients that can be treated at home, and can we do this service better. So once we have understand the demand and continue with the A3 thinking, we also try to create and to build a plan for every patient. So what we have created, and here you can see an example of the 3 different plan for every patient that we have created for the mental health subgroup. So for each archetype, we have identified what are the resources, the tasks, the clinical scales, and the medication that every single professional healthcare has to do through the whole process. And it's important, interesting seeing the importance of identify the archetypes, because if we didn't include the archetypes, the plan for every patient should be one. So now we have 3 different plans for every patient, which actually it's true that sometimes they have a lot of things in common, but at the same time they have some specific differences that are important when we are talking about patient experience. Here you can see, after doing the plan for every patient, we are also calculating the resource estimation and capacity planning, because we really want to be more efficient. It's not about having more professional, more visits, and more. So it's about optimizing the process. So now we will start the pilot in 2 weeks, and we want to see if we need the same resources, and or if we have to change it a little bit. The plan for every patient, what has shown is that we have included more healthcare professionals profiles, but at the same time we have decreased the number of visits that other healthcare professionals were doing. So in terms of balance, at the end, the resources should be pretty much the same, but the profiles are different, and the intensity, depending on each part of the process, has been also standardized and balanced. And then just to end up, here you can see this is the Iluo matrix. Probably most of you already know this tool. But here, the new thing is that we have also include here, you can see the users and caregivers. So we also expect them to participate on the project during the process. So we ask them to do some of the tasks that were already done by healthcare professionals. So we are trying to empower them to be part of their care. Just to end up, these are the conclusions that one of the coordinators of the projects, one healthcare professional, said. And I think it's interesting that the healthcare professionals ended up with these conclusions. She said that the transformation of the hospital at home model is needed to adapt it to current times, that it is possible to standardize practices and services across different teams and regions. So at the beginning, they say, oh, this is impossible, we cannot standardize, there's a lot of variability. But at the end, they see that there are some patterns, some common patterns that we can take as a baseline. Then they also realized that it was very interesting to include the voice of patient, because actually we are redefining a little bit the plan for every patient that they need. And actually standardizing all this information makes the process more efficient. So here we don't have a lot of time to talk about the platform, but as we have already mentioned, all this program already has also a platform which are not only for the healthcare professionals to improve the coordination, but also for the family, for patients and caregivers. Because as I've already mentioned before with the Iluo matrix, we want them to be part of the process. So actually,
just to add, sorry,
sure,
Alice,
sure.
just a thing. And also we have developed some specific contents for the different plans for every patients that we have identified. So this is one thing that we have also adapted, and I think that it will give a really good experience to both familiars and the caregivers. Sorry.
No, great. Thank you. So the last slide, and then we'll see if we have some questions. But actually, we really think, and the experience show us that it's very, very important to combine both perspectives. Lean thinking provides us the systems and tools, but then also the patient experience give us the purpose and the direction. So actually, we want efficiency, but we are working on the healthcare sector, and we also want to meaningful. And it's really important to include this perspective in the client. And as Ellie already showed you, the first principle of the lean methodology is about understanding the demand, but not only in terms of numbers and capacity and, but also in terms of experience. So I think that the lean methodology is more powerful when you combine both points of views. So thank you very much. And now if someone has some questions.
Yeah, I will stop sharing my screen and I will see the questions.
Here we have one comment. Design thinking focuses on patient's experience and is surely important. However, for psychiatry patients, it is not necessary that is leading, I think. A compassionate heart is sometimes needed and not that of the patient. What is your view? I think it's like, I agree, but then at the same time, I think that it's needed to at least listen what they expect and what they want. It's true that with mental health, the focus group were not easy. And it was then when we realized that we also need to include parents and the caregivers. So it's not only about the patient, but all people who are around the patient. And maybe it's not to follow and to do all what they are expecting. And also the resources are very limited. So it's true that it's a balance between efficiency and what they expect. But not for that, I think that it's also very, very important that we listen them. Whoever is the patient profile that they have, I think that the insights that we got were really enrichful.
Okay, so here we have another one. It is great that we are focusing on the various process groups. However, I feel we are not focusing on the effectiveness of the treatment. Is the diagnosis good? Is the change plan working? And if the treatment is really addressing according to change plan? And how are we learning along the way to modify it necessary the diagnosis? Are we using lean to treat the patients better?
You wanna go or?
Yeah, go for it.
Well, totally yes. We are using also the lean principles. As we have already shared with you, we also had all the observation, and we also had all the volumes and the data. The data is really necessary to do it, and we are more efficient. So that's what I also try to explain you. We will start the pilot in 2 weeks, and we will see, but up to now, the numbers that we have is that the process will be more efficient, but we also have adapt the profiles that are participating to be more addressed what the patients expect and need. So hopefully we are using, yes, both methodologies. We are not missing lean because of patients. I think it has to be a balance. And again, the in health, well, in all sectors, but above all in the healthcare sectors, resources, at least here in Spain and Catalonia, are very limited. So we need to be very, very efficient because there are a lot of waiting lists, and we need to be very efficient.
Great. So I think that we don't have any more questions. Thank you very much. Very great. So I think that we can finish the presentation.
We are done because of the time.
Yeah, thank you so much for attending the webinar. And if you have any question, obviously you can address us.
Yes, thank you very much, and hope you enjoy.
Thank you. Bye-bye.
Bye.